All right, good evening, everyone, and thank you for joining our Men's Health webinar. We'll start with a few housekeeping items, and then I'll introduce tonight's speaker. First, your participation in tonight's webinar is completely anonymous to other attendees, and no one can see your face or your name, and any comments or questions can only be seen by myself and our speakers. If you wish to ask a question, please type it in the chat box at the lower part of your screen, and we will have a Q&A portion at the end of the presentation to address these questions. Our presentation tonight will last for approximately 1 hour and will be presented by Dr. Matthew Meadows of Uro Partners. Let me click through here. Oh, sorry. I'm trying to share the screen. It's not going to the next slide. There we are. Dr. Meadows completed his undergrad at the University of Michigan in Ann Arbor. Then he went on to complete his medical degree, internship, and urology residency at Georgetown University in Washington, D.C., serving as chief urology resident from 2003 to 2004. Dr. Meadows is a native of the Chicago area and has been a member of the medical community, practicing urology in Chicago since 2004. Thank you for joining us tonight, and now I'll turn it over to Dr. Meadows to get us started.
Thank you very much, and thank you everybody for joining us this evening. I am Dr. Matthew Meadows, as that lovely introduction said. I'm glad you all could make it tonight. We are going to discuss men's health, as the initial slide said, specifically erectile dysfunction and incontinence, but we will touch on a number of other issues that are very important to men's health, prostate issues, as well as other issues, diabetes and heart disease, which are intimately associated with erectile dysfunction and incontinence. Next slide, please.
Sorry, sometimes it has a delay, so forgive me. I'm clicking it. There we go. There we are.
So to begin, we'll talk about erectile dysfunction. This is a widely discussed topic. This is a thing that's on a lot of people's minds, but often are uncomfortable talking about or don't exactly know how to raise. What is erectile dysfunction? Who has it and what causes it? We will go into that in a lot of detail in the next slides. Next slide, please. So erectile dysfunction, a dictionary definition here, or perhaps the way it would be defined medically, the persistent inability to achieve or maintain an erection firm enough to have sexual intercourse. As this is a very personal disease, it affects not just the patient, but also the patient's partner, as well as the patient's relationship. I think the definition needs to be more personalized. Any man who is dissatisfied with their erections, the quality of their erections, if their erections are not allowing them and or their partners to have a satisfactory sex life, I would consider that erectile dysfunction, and we should at least discuss if there's ways to treat it. How prevalent is it? How many people suffer from this? 1 in 5 men in the United States, we'll go back a couple slides, are thought to have erectile dysfunction. More than half of men over 40 have some degree of erectile dysfunction. Again, I don't like to get caught up in these numbers. It's a very individual thing, I think. If you're one man who has it, it doesn't really matter to you who else it does. The thing I would take away is that this is very common. It becomes much more common as men age. I don't want to say it's inevitable, but there are certain diseases of aging, which we'll discuss, that lead to erectile dysfunction. Next slide, please. To understand some of these disease processes we'll discuss and how they lead to erectile dysfunction, as well as to understand erectile dysfunction in general, I think it's important to first understand how do things work when they work perfectly. When a patient is aroused, interested in sex, nerves surrounding the penis become active, and those nerves open up the blood vessels to the penis. And that allows more blood to flow into the penis. The blood becomes trapped in the penis, and the penis becomes erect. In the illustration on the right here, the first cross-section in the upper left-hand corner, the flaccid penis, you can see this spongy tissue that is not engorged with blood. On the right, you can see the erect penis. The spongy tissue has become engorged with blood. In order for this tissue to become engorged with blood and for the penis to become erect and firm, the blood vessels have to be able to open up and carry an adequate amount of blood. So any disease process that will affect these blood vessels, that will affect blood flow, that will affect the nerves that open these blood vessels, can lead to erectile dysfunction. Next slide, please. These are some of the diseases we discussed, and I like this slide a lot because I think it touches on a lot of issues in men's health, not just erectile dysfunction. I also think it makes it important to realize that erectile dysfunction is not something trivial, as some people believe. It is an important part and marker of a man's overall health. The top three causes you see here are vascular. Under that would fall heart disease, high blood pressure, atherosclerosis, or narrowing of the arteries, as well as smoking. That is not in this slide, but smoking causes high blood pressure, causes atherosclerosis and narrowing of the arteries. Diabetes, a very common cause of erectile dysfunction. It affects both the nerves and the blood vessels that help men get erections. There are medications that can cause erectile dysfunction. Some of the medications that do treat high blood pressure can cause erectile dysfunction, as well as some medications used to treat depression or anxiety. Additionally, on the bottom left, you see prostate cancer. Prostate cancer itself does not cause erectile dysfunction, but many of the treatments that men undergo to cure their prostate cancer can lead to erectile dysfunction. And in the lower left-hand corner, I'll emphasize again heart disease. Heart disease is narrowing of the arteries to the heart. It can lead to a heart attack. Men who have to have bypass surgery or stents, those blood vessels to the heart are a great magnitude of order larger than those blood vessels to the penis. So if those blood vessels are narrowed, it's likely the blood vessels to the penis are narrowed as well, and not enough blood is getting to the penis to provide adequate erections. So takeaway, erectile dysfunction can be a signal of other disease processes going on that need to be managed and are part of men's overall better health. Next slide. When I talked about the personal aspect of erectile dysfunction, how it affects not just the patient, but also their partner and their relationships, you can see in this slide the quality of life. And I think what's real important when I'm treating patients with erectile dysfunction is the inability to have a satisfactory sex life makes people uncomfortable in their relationship. It makes them feel insecure about their health overall, makes them feel insecure about their vitality. And so I do think it's important, if it's bothering a patient and or their partner, that it be addressed for psychological health as well. Next slide. Erectile dysfunction and diabetes, there's a very, very clear connection between these two. I mentioned that diabetes, both controlled and worse uncontrolled, damages all the nerves and blood vessels in a patient's body. Patients who have diabetes, patients who have had complications from diabetes may have issues with their vision, they may have issues with their kidneys, they may have issues with neuropathy and blood flow to their toes. These are all very small blood vessels and nerves in their body that are being affected. The blood vessels to the penis are no exception, and men with diabetes are much more likely to have erectile dysfunction. Controlling a man's diabetes helps to limit the effect diabetes can have on erectile dysfunction. But you can see from this slide that men who have diabetes, on top of having more erectile dysfunction, have more difficulties with it. They have more severe erectile dysfunction. It occurs earlier in life. They have less response to oral treatments. That would be Viagra, Cialis, or sildenafil and tadalafil, as they're now known. And diabetes also is often associated with obesity, which we haven't talked about yet. Obesity, very associated with erectile dysfunction because men are more prone to diabetes, atherosclerosis, high blood pressure, and low testosterone, which we'll talk about later. Next slide. This reviews some of what I just discussed. You see there the second point I would bring your attention to. The large number of people who have with diabetes who have nerve damage or neuropathy. If any of the patients out there have diabetes or have family members who've had diabetes, they may have experienced neuropathy either as numbness or severe pain or tingling in their extremities. They can also have this problem in the genitals, and it can lead to erectile dysfunction. Diabetes also accelerates the process of endothelial dysfunction, which you see in bold in the third bullet point there. Endothelial dysfunction is a long way of saying the blood vessels do not work well. They don't open up in response to external stimuli, meaning when things are working perfectly, when a man is aroused, when a man is in the mood, the blood vessels in the penis open up well. With diabetes, the blood vessels lose that ability, and men lose their ability to get erections. The oral medications that patients take, I referred to Viagra and Cialis. Their generic names are sildenafil and tadalafil. There are several other oral medications. These can be very effective, but they work on the nerve endings in the penis to open up the blood vessels. So if diabetes has damaged the nerves and or the blood vessels, the medicines will be less effective. They don't have somewhere to work. Next slide. Other factors when a man has diabetes that will make the erectile dysfunction worse. We've discussed age. I don't mean to be a downer, but unfortunately, all men's erections get weaker as they age. This is just aging of the blood vessels. Diabetes speeds up this aging of the blood vessels. How long has a patient had diabetes for? Meaning, how many years have the blood vessels and the nerves been exposed to these elevated sugar levels, which we know can do damage? Poor glycemic control. Higher levels of sugar, men whose hemoglobin A1Cs or sugars are routinely high. For those of you who don't have diabetes, these are blood tests we use to monitor the control of diabetes, will have worse erectile dysfunction. Additionally, the presence of microvascular complications, those are the other complications I alluded to that can come with diabetes in the eyes, the extremities, the toes and feet, the kidneys, the heart as well. Diuretic treatment, that's medications that men are often on when they have diabetes that can lead to erectile dysfunction. And cardiovascular disease, or narrowing of the blood vessels to the heart, the blood vessels throughout the body, which goes along with diabetes. Next slide. Men with diabetes, and this is what I was just referring to with cardiovascular, are at higher risk for heart disease. Unfortunately, if any patients there are diabetic, I'm sure your doctors have told you, that puts you at a greater risk of heart attack, heart disease, needing medicine for your heart, and that also puts you at much greater risk of erectile dysfunction. Oftentimes, erectile dysfunction can be one of the first ways we find out that men have heart disease, and it's important that this be treated. Narrowing of the blood vessels to the heart can obviously lead to a heart attack. Narrowing of the blood vessels to the brain can lead to a stroke. So when we identify erectile dysfunction in a man, we do recommend they get screened with routine blood work, blood pressure measurements to make sure that none of these other things are going on. Again, I bring this up to say that erectile dysfunction is not something trivial, in my opinion, as it can be the sign of much more serious health problems that contribute to men's overall health. And so it's important that we talk about, feel comfortable talking about, and feel comfortable addressing erectile dysfunction, because it can help us address other health problems. Next slide. Heart disease, we've begun to touch on. Again, this is saying the same thing we just said. Erectile dysfunction can be a warning of more serious things going on. The vessels to the penis, as I said earlier, are much smaller than the vessels to the heart. As they're narrowing, either due to high blood pressure, diabetes, smoking, even high cholesterol, we will start to see erectile problems probably long before we'll see heart problems. So erectile dysfunction, when we see it, we need to make sure there's not also heart issues going on, make sure those are managed. Next slide. Here you see what I keep referring to. These 4 red circles are supposed to show the size of an artery. That is the blood vessel that brings blood into an organ. On the far left is the penile artery, which you can see is significantly smaller than the carotid artery, which is the second from the left, which would bring blood vessel to the heart. I'm sorry, the coronary artery. The carotid artery is there, which would bring blood to your brain, and the femoral artery, which would bring blood to your leg. Patients with diabetes or peripheral vascular disease can often have what's called claudication, meaning when they walk, they get pain in their calves. They're not getting enough blood to their lower extremities. This, I think, illustrates pretty well with the penile artery being narrower. We may see erectile dysfunction before we see significant symptoms in these other important areas, but it means that the disease process, the narrowing of the blood vessels, is going on there as well. Next slide. How to reduce your risk of developing erectile dysfunction. I spoke some about obesity. You can see these healthy lifestyle choices. All of these things will help to decrease obesity. Diet, exercise, and physical activity. In a bit, we will talk about testosterone. That is the male hormone. That's what allows men like myself and you to have lower voices, grow a beard, have more muscle. Testosterone is important to normal erectile function. Ways to raise a man's testosterone normally are diet and exercise, as well as weight loss. Quitting smoking is essential. Smoking does great damage to every blood vessel in your body. The penis is no exception. And men who smoke have a much greater incidence of erectile dysfunction. Additionally, when possible, managing or reducing stress and anxiety. Our body's response, if we are under a lot of stress or anxiety, the body thinks it's really not a good time to be reproducing or, say, engaging in sexual relations. So it will shunt blood away from the penis. So If men are under a lot of stress, they may temporarily experience erectile dysfunction. Next slide. Low testosterone, I alluded to before. What is testosterone? Testosterone is a hormone made by the testicles. I told you before, it's what differentiates men from women. Testosterone does decrease as men age. It goes down about 1% every year after the age of 40. Testosterone is important to keep up the health of the erectile tissues. Those slides we looked at very early with the penis becoming engorged with blood, those tissues are dependent on normal levels of testosterone. In a day-to-day functioning, testosterone has a lot to do with a man's libido or interest in sex. Men who have low testosterone may be less interested in sex. They just may not feel that it's important to them. They also may have decreased energy and decreased motivation. There are some other health issues that go along with low testosterone. Testosterone can be screened for with some simple blood tests. And if indicated, we can replace testosterone, meaning give men testosterone through either shots or gels to help them feel more energetic, help them have more, feel more kind of alive, more vital, have more motivation. Having a normal testosterone does not guarantee normal erections, but having a low testosterone is certainly not good for men's erections. You can see on the right-hand side of the screen that this is quite a common condition as men get older. 4 in 10 men over the age of 45 have low testosterone. I have many patients I treat with low testosterone, and they feel much better when it is treated. It is something I check routinely in men who present with erectile dysfunction. Risk factors for having low testosterone here, again, I've mentioned several times, being overweight, diabetes, high cholesterol, high blood pressure. I would also add in there are some medications men take. Men who've taken muscle building steroids in the past may not produce testosterone adequately themselves. Additionally, men who take chronic opioids for chronic pain tend to have very low testosterone. So these are things we always ask about. These are things, if we can limit them, can help men to continue producing testosterone on their own and hopefully have a more satisfying sex life and better erections. Next slide. These are some of the signs and symptoms, just to review them. You can see on the left, decreased muscle and strength, fatigue, loss of energy, some of the mental things. I would tell you all these things if you think it may add up to a less satisfactory sex life. If you have less motivation, less self-confidence, if you're feeling kind of down and fatigued, and on the right, the reduced sex drive or libido and erectile dysfunctions. Next slide. I talked about some of the treatment options. There's transdermal gels. These come in something that looks like a hand sanitizer or lotion that men can rub on each day. There's patches men can wear. There recently have been some the first ever approved oral medication for testosterone replacement. There are numerous supplements out there. Frank Thomas, amongst many other people, endorses them. I don't usually recommend these supplements for men. They don't tend to be very effective. Testosterone, usually when taken orally, is broken down in the liver, so it never makes it into the bloodstream. Injections, which we can give in several different forms, tend to be the most effective way to raise men's testosterone. The best natural way to raise the testosterone, I will emphasize again, and I emphasize to patients all the time: exercise, lose weight, physical activity. Now we're going to get into talking about prostate cancer, another disease that is unfortunately very common in men as they age, but fortunately is very curable if caught early. As I said before, prostate cancer in and of itself does not cause erectile dysfunction. However, when we treat prostate cancer, either with surgical removal or with radiation treatment, the nerves and blood vessels that go to the penis to help a man get an erection can be damaged. Not through anybody doing anything wrong, just because, as you see in the upper right-hand corner here, those nerves are intimately associated with the prostate. And so anytime we do something to the prostate to kill the cancer, those nerves can also be influenced. In the lower right-hand corner, you see the image after the prostate has been removed and the nerves have been preserved. Even with that preservation, erections are usually not the same, and there is a period of recovery after prostate cancer surgery. A couple other sexual conditions I always get questions about: after the prostate is removed, a man can orgasm, a man can have erections. There will be no ejaculate. Most of the ejaculate is produced by the prostate gland. Men who have diabetes, high blood pressure, are obese, are smokers before having prostate cancer treatment have a much greater incidence of erectile dysfunction after prostate cancer treatment. So another reason to pursue a healthy lifestyle and manage those conditions if you have them. Next slide. These are some of the numbers regarding erectile dysfunction. You can see they're kind of all over the place. Erectile dysfunction affects 25 to 75% of men. Why is that such a large range? Well, I think it's, we don't always know what men's erectile function is going into their prostate cancer treatment. Unfortunately, I usually counsel men, the erections will certainly not get better after prostate cancer treatment. Where they start from, things will probably get worse. A man who already has erectile dysfunction before treatment will likely have much more severe erectile dysfunction. You can see here that between surgery and radiation, the erectile dysfunction after enough years tends to be about equal. Again, older patients who have more comorbidities tend to be more likely to get radiation than those who get surgery. So it's hard to make these comparisons. And with the wide ranges here, you can see that this is not easy to study very accurately. The takeaway would be whatever treatment a man has for prostate cancer is likely to affect the erections. There are treatments for erectile dysfunction after prostate cancer treatment, and we'll get into that, but we have to counsel all men before prostate cancer treatment. There's likely to be some effect on their erections. Next slide. Very briefly, I'm going to discuss Peyronie's disease. This is something you may have heard about. There are some new and exciting treatments for this within the last several years, so there's more direct-to-patient marketing. Some patients listening may have this. This can have an association with erectile dysfunction. Peyronie's disease is the curvature of the erection. You can see in the drawing in the lower left-hand corner here, basically a scar forms in that spongy tissue where the that becomes engorged with blood and forms the erection, causing the erection to bend, meaning that tube that fills with blood cannot fill symmetrically. It's always a silly analogy, but it's very easy for patients to understand. It's like if you had one of those long balloons that they make the poodles out of, and you pinch it at one place, it will curve. The same thing happens to men's erections when they have Peyronie's disease, as you can see here. If the penis is not so curved that it's inhibiting a man's ability to have sex or enjoy sex, there's not really any treatment needed. If it is inhibiting or limiting a man's ability to enjoy sex, there are medications we can inject into these scars to make them less firm and decrease the curvature, or there's surgery. Over time, these scars can lead to some degree of erectile dysfunction. It's not clear exactly if that's actually a physical thing or if men become very anxious or uncomfortable with how their erection looks, leading to erectile dysfunction. But if this is a condition that a man is suffering from, we do have treatments for them. It's not something people just have to live with. Next slide. This is what we were talking about. Can erectile dysfunction be a symptom of Peyronie's disease? The two do tend to go together. It's not quite clear if that's because the scar limits the blood flow into the penis. There's probably some of that, as well as some anxiety component. Next slide. The treatment options, very briefly, the medication, which is new and has been marketed, some of you may have received marketing materials, is called Xiaflex. This is a medication we inject directly into these scars to loosen them up over time. If that doesn't work, there is surgery where the scar can be excised or incised, a number of things we can do to make the penis straighter and the erections firmer. Next slide. So erectile restoration treatment options, that's a fancy word for erectile dysfunction treatments. This is who can treat erectile dysfunction. Some general practitioners are comfortable discussing it. If not, I would encourage you to see a urologist. Most urologists are comfortable understanding the mechanisms and treatments for erectile dysfunction. There are urologists who tend to specialize in treating erectile dysfunction. It is a particular interest of mine and tend to specialize in doing treatments as well as surgery for erectile dysfunction, which we'll discuss next. Here are the treatment options you can see in these 5 drawings at the bottom. The oral medications on the left we have discussed. Tadalafil or sildenafil, also known as Cialis and Viagra, are the most popular. There are injections. What you're seeing there in the lower left-hand corner of that illustration is a man injecting medicine directly into the penis. These work much like Viagra or Cialis by opening up the blood vessels. However, they bypass the need for the blood vessels to deliver the medicine to the penis. These are very effective. However, many men are reluctant to give themselves injections. It can be painful when the injections are done. They're slightly more effective than the oral medications in men who have diabetes. I'll call your attention over to the right for two things we don't use very commonly anymore. Urethral suppositories. These are small little pellets that are put into the end of the penis and dilate the blood vessels. Vacuum erection devices, which can be very effective. Unfortunately, it's a little awkward for many patients. They have to put a silicone cylinder over the penis and create a negative pressure by pumping on that, and then wear a ring at the base of the penis while having sex. Some patients, though, are very satisfied with it. Again, I want patients and their partners to have a satisfactory sexual experience. In the middle there, you see penile implants. This is a very effective treatment, although it requires a surgical operation for men who have failed the oral medications or some of these other treatments, where we implant two inflatable cylinders into the penis, and the man can create an erection whenever he wants and is ready to have sex. This gives the most reliable erection, but comes with its own drawbacks of having surgery. However, patients who do this do report the highest levels of satisfaction because of the reliability of the erection. We'll go into all these in a little more detail. Here's the oral medications. We've talked a lot about them. They increase blood flow to the penis, usually taken close to sexual activity, although some of them can be taken on a daily basis. These are very effective. Unfortunately, they're very effective in the initial stages of erectile dysfunction, when a man has mild erectile dysfunction. As a man ages, as the atherosclerosis or narrowing of the blood vessels progresses, if the diabetes and high blood pressure are not well managed, if a man continues to smoke, the vessels will narrow and narrow. And often what we see is, whereas at one point Cialis or Viagra worked well, as a man ages, it works less and less well. We've talked before, and you can see at the bottom of the slide, this is very true for men with diabetes, where the disease, which is a disease of the nerves and blood vessels, erectile dysfunction, continues to progress. And whereas the Cialis may work 1 year, 5, 10 years down the road, it may not. So what do we do then? Next slide. Sorry, very briefly. People ask all the time, are these medicines safe? I think they are very, very safe. There are side effects, which can obviously make a man not interested in having sex: headache, facial flushing, stuffy nose, upset stomach. Men who have active heart disease, meaning have regular chest pain, are the only group who should not take these medicines. If a man has high blood pressure, if a man has had heart disease in the past but is not having any chest pain, it is perfectly safe to take these. Next slide. This is the vacuum erection device. I talked a little about how it works. Patients can be satisfied. However, it is somewhat awkward. You have to have a partner who is comfortable with doing this. Again, you're wearing a ring on the base of the penis, which some patients find awkward. This can be used in conjunction with oral medications as well, and sometimes that's very effective for patients. Next slide. Here's some of the things people don't like about it. I think you could figure most of these out yourself. There can be some bruising, some discomfort, and the lack of spontaneity is really what makes most patients seek another treatment option. Next slide. The urethral suppository, the brand name is Meadows. This is very rarely used any longer. I don't know that I have any patients who are still using it. If a patient is happy with the treatment they're having, there's no problem there. The most common side effect is some pain in the penis with putting in this in the end of the penis. This is more of a historical thing at this point. Next slide. Injection therapy. This is very effective, and this actually predates Viagra or any oral medications. It is injected into the penis, again, about 20 to 30 minutes before sex. That decreases the spontaneity somewhat. It can be painful. You can form scars where this injection takes place. There is a risk of what's called priapism, or an erection that won't go away. While initially that sounds great, after a few hours it becomes quite painful and is a surgical emergency. The reasons patients don't love this therapy: they're uncomfortable with injections, they don't have the ability to give themselves injections, or ultimately they don't get erections with this. Next slide. And that leads us to the penile implant. When these other treatments have not worked or are not palatable, or a man is not satisfied with them, we have a surgical option we can offer, and that is a penile implant. You can see on the left here the man squeezing his scrotum. What he is doing there is pumping a part of the device, which is filling the two cylinders which have been placed in the penis, causing the penis to become hard and have an erection. This is very effective. When a patient wants an erection, all they have to do is squeeze this 6 or 7 times, and they have a firm, erect penis. When they do not want to use it, the penis is soft. Nobody else can tell that anything is in there. There are always side effects or risks. There's a small risk of infection. That's a little higher in diabetes. Over time, there can be a mechanical malfunction. We can replace these devices. Some patients have some pain, but patients tend to be very happy. As you can see, 98% of patients, they can get an erection on demand. They can get multiple erections in a day. Patients do still ejaculate normally if they still have their prostate in place. You urinate normally. After recovering from this operation, people are usually very satisfied. Next slide. This is actually a little bit of an animation. I will talk you through what's going on here. So this is the male anatomy. You can see here the man is squeezing the pump in the scrotum. What we're seeing with that green is the fluid that is flowing from that reservoir, which is in the top of the picture, is filling the cylinders with fluid, causing the penis to become erect and rigid. And then when the man is done, there's a button he can push on there, which causes the fluid to leave the penis, and the penis goes back to its flaccid state. So this is very closely mimicking normal functions. Now, just to show you this can actually be done, this is a live patient inflating and deflating the penile prosthesis. This is something that if a patient has this, we go through with them very clearly and instruct them how to do it. You can see on this patient, you can't tell that there's been anything abnormal implanted. He's squeezing the pump, and we can see the penis has become erect. It is standing up rigid, and he's ready to go. Again, very possible to do this without the partner having any idea. When he turned towards the front there, you could actually see the very small scar that a man has after this operation. The deflation, there's another part of the button. Again, patients who have this are well acquainted with how this works. He squeezes that, the fluid is leaving those cylinders, and the penis is returning to a soft, flaccid state where nobody would be able to tell anything was going on there. So very discreet. Patients tend to be very happy with this, as do their partners. What are the benefits? Well, I talked about this is a permanent solution. This is not taking a pill and then crossing your fingers and hoping that it works. It allows for a lot more spontaneity. The erection lasts as long as you desire. As you could see from that video, this is entirely contained inside the body. I mentioned that this does not interfere with ejaculation or orgasm in any way. This is a treatment that has been around for a number of years. The first penile implant, I believe, was done in the late 1960s, early 1970s. So this is not something terribly new. The devices have been refined and continue to be refined. Next slide. This is usually covered by insurance. Obviously, before having any surgery, your surgeon, the hospital, and you would all want to check on that. Next slide. Some of the risks were obviously, we have to tell that, and we want every patient to know that before they go in. I mentioned an infection, mechanical failure. In those cases, the implant can, if it needs to, be removed and a new implant can be placed. There can be some pain in the healing process. Usually by about 4 weeks after surgery, men are able to use the implant to have sex. Next slide. So to summarize, erectile dysfunction is a common problem. It can be associated with a number of other health conditions that are very important for screening for, very important parts of men's overall health. There are a number of treatment options. Penile implants is not the only one. There are a number of treatment options. If a man is suffering from erectile dysfunction, either anyone here, anyone you know, I encourage you to speak to your doctor, either your general practitioner if you're concerned about these other health issues, or a urologist or a specialist in treating erectile dysfunction. You can see the website at the bottom there, edcure.org, has a bunch more information if you're interested. Next slide. Okay, that's going to end the part where we speak about erectile dysfunction, and we're going to move over to talking about another problem that men have, stress urinary incontinence. This is the loss of control of urine. In most men, this comes on after some form of pelvic surgery. Next slide. Stress incontinence is when a man leaks urine in response to some kind of pressure or stress on the abdomen. This can be coughing, laughing, sneezing, dancing, lifting weights. Basically, the muscles of the pelvic floor are not strong enough any longer to keep the urine from leaking with this added pressure. This is also a condition women have. The treatments are in some ways similar, in some ways very different. In most men, this stress urinary incontinence comes on after some form of pelvic surgery, by far most commonly surgery on the prostate. Also can be seen in men who have neurologic disorders, either spinal injuries or disc problems or things like that. Next slide. This is a good anatomic diagram to show how the urine is controlled under normal conditions. The picture on the right is what we call a sagittal section. This is though we cut the man down the middle and we're looking in from the side. You can see the bladder where the urine is stored. The urethra, which is what the man urinates through, runs right through the center of the prostate. And the prostate is intimately associated with what is labeled as the sphincter, the muscle that helps to control the urine, keeps the urine from leaking out. When the prostate is removed, it has to be peeled off the sphincter. And much like we discussed with the nerves that help you get an erection, the sphincter may not be as strong afterwards, and a man may suffer incontinence. The sphincter can also be damaged in surgery on the colon, but much more commonly, surgery on the prostate. And we can do things to strengthen the sphincter and help men with their incontinence. Next slide. As I've said, strongly correlates with prostate cancer surgery. The numbers there about men who have incontinence or leakage of urine after prostate cancer surgery, not as widely variable as erectile dysfunction, but still a significant number of men. Other things that can lead to that, I've discussed the neurologic disorders, severe pelvic trauma, as well as radiation for prostate cancer. Next slide. Leaking urine doesn't make anybody happy. It can obviously affect your quality of life. And it makes me very sad. And I always try to counsel patients, if they're concerned about their urinating, they're concerned about leaking, is keeping them from doing the things they'd like to do, whether that's playing golf, whether that's exercising, whether that's socializing, traveling, visiting with friends, then it's a problem that I think we should discuss addressing. Next slide. Okay. So here's the same diagram on the right of what we do when we do prostate cancer surgery. In the lower right-hand corner, you can see the prostate has been removed, and now we are looking at the urethral sphincter there, which has to be sewn back to the bladder. In doing this surgery, it is always possible that the urethral sphincter does not recover strong enough to help men have control. All men have brief periods of incontinence after prostate cancer surgery, but most men have a good degree of control by about 12 weeks after, some men as soon as 4 weeks. For men in whom the incontinence continues up to about a year after surgery, I do counsel them about surgical options that are available. Next slide. This is just repeating most of what I said. Incontinence is normal after prostatectomy. Doing exercises to strengthen the pelvic floor can help speed the recovery of urinary control or continence. Next slide. Here are some of the treatment options. Again, we discussed before, urologists specialize in this, and there are urologists who even subspecialize with it. I am very interested in helping men with their incontinence and enjoy doing these operations because it leads to very satisfied patients. Next slide. Easy things to do, behavioral modifications, timing when a man goes to the bathroom. There are bladder stimulants that make this problem worse. Caffeine, even non-caffeinated coffees, teas, sodas, energy drinks, alcohol, these all make men have more urgency and can worsen incontinence. Pelvic floor physical therapy, biofeedback, and Kegel exercises. These are some of the things I discussed with helping to strengthen the pelvic floor muscles and helping a man control the urine better. The column on the right, I don't really think belongs on a treatment slide. It's just kind of coping. What do you do to not wet yourself? What do you do to make this livable? Pads, diapers, catheters, penile clamps. Any men I see who are using these, I discuss, is there something more we can do so that you don't have to live with this, constantly changing these things, constantly being worried you have enough of them. I like to offer them other treatments. The expense of these short-term coping mechanisms is significant. For any patients here who have had to go through this or use them, you could testify to that. Next slide. Here are the long-term treatment options, or the more curative treatment options. There's really two very good operations for incontinence after a prostatectomy or after any of these damages, anything that has damaged the external urinary sphincter. On the left side is the male sling. On the right side is the artificial urinary sphincter. And we'll see some graphics of these operations in a second. The male sling helps to support the urethra to better control urine. It is appropriate for cases of mild to moderate stress urinary incontinence. These are men who are mostly dry probably while they're sleeping, dry while they're sitting still, but leak some urine when they're more active. It involves putting a soft mesh under the urethra to kind of tighten up that muscle, which gives just enough support that the leakage stops. The artificial urinary sphincter is for more severe degrees of incontinence. Unfortunately, there are some patients who have just drip levels of incontinence. And for them, I think the artificial urinary sphincter is the best operation, very effective. Next slide. The benefits of the male sling, here this is referred to as a minimally invasive procedure. I always caution patients, if you're the patient, nothing's minimally invasive, but the incision is quite small. It's made between the testicles and the anus, what we call the perineum. Most men can resume most of their activities. 1 to 2 weeks might be a little soon. I don't want men riding a bike, squatting, climbing a ladder, but feel pretty good within 1 to 2 weeks. In order to urinate, you urinate normally as you would have before. There's just more pressure to keep the urine in so that they don't leak during activities. Next slide. The artificial urinary sphincter, this is a balloon. Again, we'll see this in a moment. It is a circumferential balloon that goes around the urethra and shuts the urethra and has a pump, much like the penile prosthesis we saw, so that when a man has the feeling of needing to go to the bathroom when the bladder's full, he can pump this pump in the scrotum, which deflates the balloon and allows him to urinate. Again, like the penile prosthesis, it's entirely inside the body. It is not detectable to others. The difference between this and the sling is whenever a man needs to urinate, he needs to do something. It's not as simple as just standing at the toilet or sitting if he prefers. There is something that needs to be inflated and deflated. Next slide. This is an animation, which I think will make a little more sense after I talked about a circumferential balloon. What are we talking about here? So what you see on the left side of this man's scrotum is the pump that is used to inflate and deflate this balloon. In the upper left-hand corner, you see that circumferential balloon deflating, allowing the urine to pass out, and then the balloon passively inflates, compressing the urethra so there's no more leakage. For those of you listening who may have incontinence, who may have family members or friends who are suffering from incontinence, I would encourage you to talk to your doctor, talk to a urologist, if there are solutions for you. There are other reasons for incontinence besides stress incontinence, and urologists can help with those as well. Here tonight, we've addressed 2 surgical solutions for stress urinary incontinence, again, seen most often after prostate cancer surgery. Next slide. Like any procedure, these are risks with both the sling and the sphincter. We are putting something foreign in the body, so there's always a risk of infection. There's always a risk of erosion. The body does not take to this, but most patients do quite well with this. Next slide. Insurance almost always covers these things, especially for men who've had prostate cancer, but again, we would check everything carefully before proceeding with anything. Next slide. So in summary, stress incontinence is something that unfortunately is common after prostate cancer treatment. It is not something people have to live with. There are good options to treat it. And if you are bothered by this or suffering from it or know somebody who is, I would encourage you to speak to a doctor and see what you can do.